Hi everyone, welcome to our module on normal structure and function of skin. Before we get into dermatological diseases, we need to build a strong foundation in how skin is normally structured and how it functions. Because in reality, most dermatology questions are not just testing random facts. They are testing whether you understand the structure first and then whether can you apply that to pathology or not. So in this lecture, we're going to move step by step from the basic structure to cellular organization and to clinical correlations. So now let's start with what the skin actually does. Before beginning with the video, I would like to request all of you to subscribe and keep supporting. This lecture series is provided free and is open access for everyone. If you find it useful and wish to support its development, you can contribute to us through the link that is on the screen and that's also pinned in the description. Can contribute to us with any of these payment methods. Now coming to the functions of skin, the skin is not just a passive covering, it is a highly active and multifunctional organ. First, it acts as a protective barrier against bacteria, toxins, and environmental damage, thereby preventing microbial invasion. Second, it prevents water loss. This is critical. If this barrier is disrupted, patients can rapidly become dehydrated. Thirdly, it plays a role in temperature regulation through blood flow and sweating. Fourth, it serves as a sensory interface, allowing us to detect touch, pain, and temperature. And finally, it has an immune function because specialized immune cells in the skin, called the Langerhans cells, can detect pathogens and initiate responses. Now, to understand how all these functions are achieved, we need to look at the structural organization of the skin. So the skin is divided into three main layers. The outermost is called as the epidermis, which is where most dermatological diseases are occurring. Below that is the dermis, which contains connective tissue, blood vessels, and nerves. And the deepest layer is the subcutaneous tissue, which is mainly composed of fat, providing insulation and cushioning. Now, here's a key point. Whenever we solve questions, clinical questions, we always need to ask ourselves which layer is involved. That alone can eliminate many options. Now, before we go deeper, let's try to understand where these layers come from. So, coming to the embryological origin of the skin, so it's extremely important because it explains many disease associations. The epidermis develops from the outer embryonic layer or the surface ectoderm. The dermis and subcutaneous tissue comes from a different embryonic source called the mesoderm, whereas melanocytes are completely unique. They arise from the neural crest cells, which migrate, and these melanocytes migrate into the epidermis during development. So, whenever we see pigmentation disorders that are associated with neurological findings, we need to think about possibly a defect with the melanocytes because they can help us in identifying this shared origin. Now that we understand the layers and their origin, let's try to focus on the most important layer on the dermatology, that's the epidermis. So, the epidermis is a multi-layered epithelial structure that is constantly renewing itself. So the epidermis is made up of stratified squamous epithelium, which is a multi-layered epithelial structure. So the cells are produced at the bottom and move upwards, eventually forming a protective barrier. So to understand this process, we need to break the epidermis into its individual layers. So there are five different layers arranged from superficial to deep. So we can remember those five layers using a simple mnemonic. So that's nothing but come, let's get sunburned is a mnemonic that we can use to remember these five layers of the epidermis. So come stands for corneum, S stratum corneum, then uh, L stands for stratum lucidum, G stands for stratum granulosum, S stands for stratum spinosum, and B stands for stratum basale. So What does this epidermis do? It provides the structural barrier, prevents water loss, and also protects against pathogens. Now let's try to understand what each layer is doing and uh, understand their role, not just like memorizing names and all. So before we go layer by layer, let's try to understand the overall process, like how it happens. So these are the layers: stratum corneum, stratum lucidum, stratum granulosum, stratum spinosum, and stratum basale. And we can remember those layers using the mnemonic. Come, let's get sunburned. So skin cell starts at the bottom, then it divides, then slowly moves upwards. So as it moves, it provides and produces more structural proteins, and it also loses its internal what do you call internal components and eventually becomes a flat dead cell. So this dead cell is not useless. It forms the protective barrier of the skin. So this entire journey is called as keratinization. Cells mature from the basal layer and reach the apical surface. So this is called as keratinization, and this eventually finally leads to dead keratin-filled barrier cells, which provide which function as a protective barrier of the skin. Now, starting with the deepest layer, the basal layer. So, this is where new skin cells are produced. Think of this as the factory of the epidermis. So, the cells are anchored firmly to the underlying structure. So, if this attachment is lost, underlying structure called basement membrane via hemidesmosomes. And if this attachment is lost, the skin can separate and can form blisters. So this stratum basale contains stem cells, and this is responsible for regeneration. And stratum basale is nothing but a single layer of cuboidal cells, and all the cells function as stem cells, and these are connected to the basement membrane via hemidesmosomes. Additionally, it also contains melanocytes, or which are also called as a pigment cells, which produce the pigment of the skin, and also the touch receptors or Merkel cells that help us sense the environment. So now, as the cells move up, they're going to form another layer called as the stratum spinosum, which is also called as the spiny layer. So here the cells are tightly connected to each other through strong junctions called as desmosomes, giving the skin the mechanical strength and all. So if these connections are disrupted, cells lose cell-to-cell adhesion. So that cell-to-cell adhesion is a key mechanism in certain is a way where they just adhere to each other. So if this cell-to-cell adhesion is lost, so that becomes a predisposition for blistering diseases. Again, so as the cells continue moving upwards, they enter the granular layer. So here they begin organizing their structural proteins into a dense network, and this is where the skin barrier really starts forming. So the skin barrier really starts forming at the stratum granulosum. So, so this stratum granulosum cells contain keratohyalin granules, and these granules help in keratin cross-linking. So as a result, this strengthens the keratin network and begins formation of the real protective barrier. Above this, in certain areas like palms and soles, there is an additional thin layer. So this is present only in thick skin. So that's called as stratum lucidum, and this appears translucent under microscopy. This is not present in thin skin. So that's what we need to remember. So in this image, we can identify the characteristic appearance of stratum lucidum, where it's present only in thick skin. Finally, the cells reach the outermost layer where they're completely flattened and are no longer alive. So these are so that's the stratum corneum, and it's composed of dead flattened cells, and cells are enucleated without presence of a nucleus. It forms the final protective barrier, prevents water loss, and blocks pathogens. Finally, to summarize, the cells start at the bottom, and as they mature, they move upwards and eventually forms the protective surface from the stratum basale to the stratum spinosum, then to the stratum granulosum, then to lucidum, and then finally stratum corneum. So as this keratinization occurs, key transformations occur. So few of them includes cell division at the basale, structural strengthening through desmosomes at the spinosum, keratin cross-linking at the granulosum, and finally a dead protective barrier at the corneum. Additionally, in thick skin, we might be finding a clear layer which is called as stratum lucidum. So this total turnover time of the entire keratinization process from the basal cells to the apical cells happens for about 28 days for each cycle. Now, here's the clinical relevance. So, different diseases affect different layers. So, if you understand the layers, we can understand the disease also. So, basal mostly contains stem cells. So, whenever it's affected, there is a characteristic regeneration disorder. Whereas, if there's a defect with the spinosum, there are structural diseases because of loss of cell to cell adhesion, whereas whenever granulosum is affected, this affects the keratin cross-linking, so there is characteristic keratin disorder. Whenever stratum corneum is affected, this leads to disability of the protective barrier and finally presents with barrier defects. So whenever there's defective keratinization, this could lead to skin diseases. Whenever there's barrier dysfunction, uh, it can lead to loss of protective barrier functioning and exposure to infections and also water loss leading to dehydration. Now let's move on to one of the most important concepts in dermatology, like how the skin cells stay connected. The integrity of the skin depends on specialized junctions that hold cells together or attach them to the underlying structures called as the intercellular junctions. If these junctions fail, what happens is the skin separates. So this is what exactly happens in blistering diseases. Some junctions connect cells to each other and few the basement membrane and all. So these intercellular junctions maintain the structural cohesion, prevent fluid leakage, and enable communication between cells. Many skin diseases target these junctions. So tight junctions or zonula occludens. So if whenever uh, these junctions are affected, this could lead to uh, tumor metastasis. So the main role of tight junctions is that to maintain and or prevent movement of substances between cells. So the proteins that are present in these tight or adherence junctions includes claudins and occludins, whereas in adherence junctions, it's cadherins that are present. And the function of these adherence junctions is to connect actin cytoskeletons of adjacent cells. Whenever there is loss of this E-cadherin, it can lead to tumor metastasis. Whereas desmosomes connect adjacent epidermal cells, and the proteins that are associated with desmosomes includes desmoglein 1 and desmoglein 3, and the other protein is desmoplakin. The function of these desmosomes is to provide strong mechanical attachment. So these desmosomes are the target in pemphigus vulgaris, where it's characterized by autoantibodies which destroy the desmosomes, and this eventually leads to acantholysis or cell separation. Whereas hemidesmosomes connect basal cells to the basement membrane, and the proteins that are associated with hemidesmosomes includes integrins and collagen 17. So the function of these semidesmosomes is to adhere or anchor epidermis to the dermis. So these semidesmosomes are a target in bullous pemphigoid, and this causes subepidermal blistering. Gap junctions are basically uh, associated with communication that's happening between the cells. So as a result of that, this helps maintain the synchrony between the interconnected or adjacent cells. So the proteins that are present in gap junctions are connexons, and these function function in a way allowing communication between cells. Whereas integrins, the main function is to maintain the basement membrane stability, because these integrins are mainly associated with uh, or what we already discussed, hemidesmosomes. These integrins are associated with proteins like fibronectin and laminin. Now, coming to understanding how the pigmentation happens. So, this pigment is produced, melanin pigment is produced by specialized cells which are derived from the neural crest, and these cells are called as melanocytes. These melanocytes are found in the stratum basale. So, melanin is synthesized in melanosomes. And these melanosomes are the specialized organelles within these melanocytes. So, melanin synthesis occurs uh, beginning with the tyrosine as a precursor molecule, and the enzyme that's involved in the synthesis of melanin from tyrosine is tyrosinase. The process is that melanin is produced inside these melanosomes, and then it's transferred to the surrounding keratinocytes where melanin accumulates, and this leads to pigmentation of those keratinocytes. So this melanin protects nuclear DNA and other genetic material from ultraviolet radiation, and also helps prevent cancers. Now let's move to some extremely important topics like albinism, vitiligo, and other pigmentation disorders. The most important point that's tested in exams is the pigmentation disorders. So, albinism and vitiligo are two of them. Albinism is associated with a normal melanocyte number and there's reduced melanin production. The cause of this albinism is tyrosinase deficiency, which leads to accumulation of tyrosine and reduced melanin, because this tyrosinase is required for the conversion of tyrosine to melanin. Clinically, it's characterized by generalized hypopigmentation, and there's an increased risk of skin cancer. There's generalized hypopigmentation involving all the parts of the body, whereas vitiligo is nothing but autoimmune destruction of melanocytes associated with patchy depigmented areas, and this is also associated with autoimmune diseases again. So the main characteristic difference between vitiligo and albinism is that albinism is a generalized hypopigmentation disorder, whereas vitiligo is characterized by patchy hypo or depigmented areas. Now moving to melasma. This melasma is mainly seen in pregnant women and those women who are using oral contraceptive pills. The cause of this condition is the hormonal stimulation. Clinically, this melasma is characterized by symmetrical hyperpigmented matches. So the symmetry can mostly be involving the face at regions like centrofacial involvement, mandibular involvement, and malar involvement. So the nickname of this melasma is it's also called the mask of pregnancy. Now let's try to understand about Waardenburg syndrome, which is another very important example of pigmentation disorders. The cause of this Waardenburg syndrome is a defect in neural crest cell migration. So as we have all discussed, so whenever there's depigmentation disorders along with associated nerve defects, we need to think about if the origin could be melanocytes. So, one of those disorders where melanocytes are directly involved is the Waardenburg syndrome. In this syndrome, it's clinically characterized by patchy depigmentation, white forelock, and congenital deafness. Whenever there's pigment disorder associated with a neural tube defect or neural crest or neural system defects, we need to think about possibility of melanocyte being an origin of that disorder. So before diagnosing anything, we must identify whether the lesion is flat or raised or whether it's fluid filled or not. So once we classify the lesion correctly, the diagnosing process becomes very much easier. So there are few microscopic terms that we need to clearly know before trying to understand and diagnose common dermatological conditions. So a few of those are what we're going to discuss right now. So there are a few examples of primary skin lesions includes macule, so patch, papule, and plaque. So macule is nothing but a flat skin lesion associated with a color change, and this is generally less than 1 centimeter, whereas patch is also a flat lesion, but it's characteristically greater than 1 centimeter in size. So a macule that's greater than 1 centimeter in size is called as a patch. To be to be concise, to be brief, so a patch is nothing but a macule greater than 1 centimeter. The example of a macule is a seen in condition like freckle, whereas patches are seen in condition like vitiligo. Now coming to elevated primary skin lesions. So whenever elevated solid lesion is seen and that's less than 1 centimeter in size, we need to call it as a papule. And the common example of papule is acne that most of us suffer with, whereas plaque is also an elevated skin lesion, but this is greater than 1 centimeter in size. So it's most commonly seen in conditions like psoriasis. So whenever papule is greater than 1 centimeter, we can call it a plaque. Alongside primary skin lesions, we have few other lesions called as the fluid-filled lesions, and this is characterized by a vesicle with with or without pus. So a vesicle is nothing but a small fluid-filled lesion. So whenever it's less than 1 centimeter, it's called as a vesicle. When this vesicle is larger than 1 centimeter, we need to call it as a bulla. So vesicle less than 1 centimeter, bulla greater than 1 centimeter. So whenever there's pus, whenever whenever this fluid-filled lesion contains pus, we can call it as a pustule. And these pustules are mainly seen in conditions like pustular psoriasis. Bulla are seen in bullous pemphigoid, and vesicles are characteristically seen in chickenpox and shingles. There's another fluid-filled lesion and this fluid accumulation occurs due to transient swelling due to edema, and this is commonly seen in urticaria, which is a hypersensitivity disorder. Now let's try to understand the basic microscopic terminology at the cellular level. So this helps us link the structure to all the kinds of diseases. Acanthosis is nothing but thickening of the stratum spinosum, whereas acantholysis, there is characteristic loss of cell-to-cell adhesion, and hyperkeratosis is associated with a thickened stratum corneum or the barrier layer. Parakeratosis is associated with retention of nuclei in the corneum, whereas spongiosis is associated with intercellular edema. Now let's just try to clinically integrate all of these. So whenever a question mentions or whenever a patient mentions that they have a lesion, what we do is examination. And when we try to examine it, We need to think, first of all, the first thing that we need to note down is whether it's a flat or a raised lesion. And then the second thing is we have to identify whether it's fluid filled or solid in case it's raised. Then we have to check at the distribution pattern, whether it's symmetric or asymmetrical in nature of distribution. Then we also need to find about the associated symptoms or clinically integrate with other systemic uh, manifestations or other systemic symptoms and signs. So whenever a question on dermatology is tested, this is how we identify the condition and try to answer those questions. Now let's just try to quickly summarize this entire module. So skin has three core layers, the epidermis, dermis, and the subcutaneous. Epidermis layers can be memorized using a mnemonic. Come, let's get sunburned. Stratum corneum, stratum lucidum, stratum granulosum, stratum spinosum, and stratum basale. Keratinization is the process where cells move from the basal layer to the apical cells, and as they move through this, nuclei are lost, and also eventually at the end become dead cells, which are mainly concerned with the role of protective barrier function. And this entire process of keratinization occurs in cycles of 28 days. Desmosome defects are associated with conditions called pemphigus, whereas hemidesmosome defects are associated with bullous pemphigoid or blistering disorders. Melanocytes, the origin is from the neural crest cells, and tyrosinase is the enzyme that's associated with melanin synthesis from tyrosin. The most important differentiation that we need to know is between the macule, papule, and the vesicle. Now, I request all of you to subscribe and keep supporting. I'll be right back with a video on disorders of skin appendages. Thank you so much. Bye.